Please invite Dr. Ameet Patki. Dr. Ameet Patki is a gynecologist in Mumbai and he's also president of ISIR. He's a ISAR Mumbai. He's a well-trained gynecologist specializing in fertility and women's health. To begin with the oration, may I please invite Dr. K. Jayakrishnan to kindly come forward and present the medal to Dr. Ameet Patki. Thank you, sir. Over to you, Doctor.
A very good morning to you, ladies and gentlemen, and thank you to Advances for having bestowed this honor to deliver Professor Chandy Oration. My association with KJK Hospital runs many years back, and I'm so pleased that I could have an opportunity to come in the last 25 years multiple times. Today, I'll be speaking on new strategies in ovarian stimulation. Now, before we start any ovarian stimulation, I think it's very mandatory that we analyze the ovarian reserve. We define the goals of our ovarian stimulation. Do we want a monofollicular as we would expect for an IUI, or you want a multifollicular as you would want it for an IVF ICSI, and then accordingly choose the correct protocols. It's very important that the ovarian stimulation is initiated by day 2 or 3, because if we wait for longer time, then nature will already determine the dominant follicle in the early follicular phase. It's important also that the patient is scanned on day 1 or day 2 to ensure that there is no cyst, the endometrium is completely sloughed off and less than 6 millimeters, and all the follicles that are there are small and less than 10 millimeters. Now, there are various drugs and protocols that are used for ovarian stimulation, and basically they all work on the HPO axis. We have insulin sensitizers, we have growth hormones and adjuvants, to which I'll come a little later. Then we have the SERMs, the clomiphene and the tamoxifen. We have the aromatase inhibitors, the letrozole and the anastrozole. Then we have the little stronger ones, which are the gonadotrophins, the LH, FSH. We have the agonist and the antagonist. And then we also have the newer ones, which are the neurokinases. Why is it important to choose the correct dose? Is because you want an optimum response in an IVF ICSI cycle, and this is between 5 to 15 oocytes. If you get more response, an excessive response, which is more than 15 oocytes, it is accompanied by sometimes large number of immature oocytes and a risk of hyperstimulation. On the other hand, if you have a poor response, less than 3-4 oocytes, it could be indicative of a diminished ovarian reserve, leading to poor pregnancy rates and perhaps higher initial dose of FSH. So you need to do the ovarian tumor markers either by sonography or by blood to know how you would manage this patient and get an optimum response. Now, we already have the pre-existing protocols that are there for the last 3 decades, and these protocols were basically the long down regulation or the short GnRH agonist protocols. And the idea was the same, to ensure that the LH surge did not happen, because that is something that you don't want it to happen until you want to give the trigger for the LH surge when you are ready for the oocytes to be retrieved. Conventional long protocol, the GnRH agonist. In some patients, we gave it as a short protocol And it's only in the last 10-15 years with the availability of the GnRH antagonist that you can go ahead with an antagon, the short protocol. We also had the low dose protocol, which we gave for maybe young patients in whom we did not want an over response, a chronic low dose, especially in severe PCOS, and a step down protocol, which we often tried when we gave a huge bolus to initiate follicular recruitment and then quickly brought the doses down to ensure that only a certain subset of these follicles grew and went on to mature. The trigger for most of the years was HCG until we started the GnRH antagon protocols, where we were had the opportunity to give the GnRH agonist as trigger to ensure again patient safety and decreased incidence of OHSS. We had the dual trigger and the double trigger, basically in patients with poor responders with low numbers, to ensure that we get most of these oocytes mature. And then in the last 5-8 years, we have gone into individualized protocols, mild stimulations, addition of LH when it is necessary, long-acting gonadotrophins, and now even long-acting GnRH antagon. Previously, infertility was only for the infertile patients. Now with social indications, egg freezings, mainly for social reasons, or egg freezing for cancer patients for fertility preservations, we now have the random start, we have the late initiation of stimulation, and even fertility preservation, different protocols. We now have the pre-treatments with estrogens, progestogens, the OC pills, and the GnRH antagons. Now, the drugs that are used for pre-treatment could be estradiol valerate, which is given 4 milligrams for 6 to 10 days before stimulation, or even the progesterone, the norethisterone or the medroxyprogesterone, given for the last 10 days of the cycle. The combined birth control pill, which we now don't recommend because we know it will further decrease the success, especially in poor responders, but can still be used in patients with severe PCOS. And the GnRH antagon, which you give for the first 3 to 5 days if you have a patient with severe PCOS and severe ALH raised, so that you bring the ALH level down, because until the ALH level is not down, the gates for recruitment do not open and you would not get good recruitment of follicles. Now, whether it is estrogen, progestogens, the birth control pill, these are probably not recommended for improving efficacy and safety. We know that it doesn't give any increase in live birth rates, but it is a good option to synchronize the follicles, especially if your patient is a cyst former patient or patients have got large early follicles. So it will not improve, but it will give you a good cohort of follicles, or also helps clinics where they have got batch IVF to ensure that you can start all the patients at the same time. When you use the GnRH, whether it's the agonist or the antagonist, we know that the agonist is the standard conventional treatment started in the previous cycle in the mid-luteal phase and continued through the stimulation. We have also used the GnRH agonist as a short protocol starting on the day of the menstrual cycle to make use of its surge response. When we started using the antagonist, there were two protocols, either the fixed or the flexible. The fixed is when you start the GnRH antagon on the 5th day of stimulation or the 6th day of the menstrual cycle, irrespective of the follicle size. When you look at the flexible protocol you gave when the leading follicles were 14 millimeters, because that is the time when your LH will start rising and will soon surge. So you start the GnRH antagonist as flexible, but when studies were conducted, they found that 50% of the flexible also fell on day 5 of stimulation. So I think most IVF centers would go with day 5 of stimulation for a GnRH antagon protocols. You also had a single dose of GnRH antagon, which is 3 grams. You give it on day 5 of stimulation, and you continue the stimulation thereafter. Now, what are the new protocols for LH suppression? This was all that we were doing till 10 years back. Now, as I said, when the indications for IVF have gone broader, when you not only include the infertile group, but also patients who want to go for fertility preservations, or the oncofertility patients where you want to do fertility preservations, don't have much time to wait till you synchronize it to their cycles, then you can start with either use of late initiation of stimulation, or you put the patients on progestogens, or you also do dual stimulations to try and get as many eggs as possible before that patient goes ahead for a chemo, radio, or surgical therapy, especially in oncocare. We now also have availability of GnRH antagon, the long antagon, which is just one dose that is given. You wait and then you can start the treatment a few days later. As I said, the ovarian estradiol is responsible for the LH surge, and progesterone can block this estradiol-induced positive feedback, and high plasma concentration of progestogen enhances the negative feedback effect of estradiol with suppressed FSH and LH secretions. GnRH analogs are not used when you use progestogens. So when you do PPO cycles, you use only progestogens through the cycle, and thereby you may marginally reduce the cost of the treatment because you're not using GnRH agonist or even antagonist. So progesterone supplementation 10 milligrams per day from day 2 to day 3 till the GnRH agonist trigger will maintain the pituitary suppressed and prevent the LH surge effectively. Now, these treatments can be done when transfer is not an option or a choice in the same treatment. Because once you put them on progestogens or you give antagon with agonist as trigger, transfer cycles do not work well because of severe luteal phase dysfunctions. In an agonist trigger, if you want to do the transfer, you will have to add the HCG on the day of the oocyte retrieval, or give very high doses of progesterones to ensure the endometrial receptivity is good. So when you look at studies for use of progestogens for LH suppression, and I've chosen the 3 largest studies that are there in record, you find that it works as effective, and medroxyprogesterone acetate versus canalilix in a donor oocyte cycle, you find that it works effective medroxyprogesterone as compared to canalilix. You find that the pregnancy rates are slightly better in the canalilix cycles, but overall it works equally well, and you can go for use of progestogens only in the context of non-transfer cycles. So when you're not planning the transfers, only then can you use these techniques. Otherwise, you may have to go for the conventional methods of long protocol or antagon protocol with HCG as the trigger. Late follicular initiation is when you start the stimulation in the follicular phase on the day 6, day 8. You find that the response is equally good. The dose that you use is slightly higher, but the number of M2s that you get are basically the same. Long-acting GnRH antagonist protocol, a bolus dose of GnRH antagon given on day 24 of the previous cycle, and you start the gonadotrophins from day 7, or in an infertile patient, you give the bolus dose on day 24 and start the gonadotrophins from day 2 or to day 8. And the long-acting GnRH antagon works effective to keep the LH level low. And the studies that have done, you see the cumulative pregnancy rates are as good as when you use the classic antagon protocol. So the single dose long-acting antagon works effectively when given in the previous cycle. It works for almost 3 weeks. So the advances that have improved the outcome, one would be individualized treatment, one would be modified natural. I don't think natural cycle is something that we would do because it gives you very poor results. Mild stimulation in young patients or good responders, random start treatments, particularly for fertility preservation, double stimulation or dual stimulation in patients for oncofertility, where you would like to try and get as many oocytes as possible. Now, people also use this in poor responders, but frankly, in poor responders, it doesn't work as well because the reserve itself is not very good. And then the use of long-acting FSH is now recently started in India, where it is effective for the first 8 days, and then you can scan the patient and see whether you need to add any more days of gonadotrophins. So based on your ovarian reserve test and other factors, which I will show you in the next slide, you decide on the dose to minimize the risk of cancellations, either for poor response or for hyper response, because at the end of the day, we have to make sure that we reduce the incidence of multiple pregnancies, and this is more commonly seen in the IUI cycle. So in the IUI cycles, we get more multiple pregnancies now than in IVF and ICSI, because we all now would want to go with a single blastocyst transfer in the advanced ART cycles. What are the other factors that affect? Age is the most important factor, and it is very important to counsel your patient when they are over the age of 35, 37, and definitely over the age of 40. BMI is something which again will decrease your success rates. We know that the Indian ethnicity is such that our age at menopause is 5 to 6 years early, so we find that our patients also have a poor reserve, and that is related to multiple things, including malnutrition, addictions, smoking, alcohol, recreational drugs. We talk about receptor polymorphism, and this is something which is coming up because in those patients, if we know that they have got polymorphism, we may want to start with a higher starting dose. Past performance is very important because you can learn from the past response and try and alter your treatment, and other infertility factors, including infections, particularly in our country, tuberculosis. So is individualized stimulation cost effective? It may not be cost effective, but it is definitely for safety and effectiveness as far as trying to get an optimum result is concerned. And that is something which is important, that you take into consideration age, BMI, ovarian reserve, and other infertility factors before you decide your starting dose. Just a little small note on natural and modified natural cycle. I think natural cycle is not cost effective. You can go for a modified natural cycle, especially when you're going for a very, very poor responder. In those patients, we know that sometimes this may help, but you have to counsel them for at least 5 to 6 cycles of such cycles, where you will try and get 1 or 2 oocytes, freeze them, and then transfer them later. But mild stimulation cycles are appropriate for the younger patients, for good responders, for PCO patients, where you use low dose gonadotrophin 75 to 150. It will also reduce the expense, reduce the incidence of hyperstimulation, and the dropout rate or all freeze that we have to do in case they have over response. So your mild stimulation cycles, you can either start with clomiphene or letrozole, and then you add the gonadotrophins, and then you continue the treatment as you would do in any other place. LH is something which is new kid on the block for the last 5 years. We all thought that the LH was necessary only for the LH surge, for cumulus oophoris maturation, follicular rupture, and oocyte expulsion. But we now know, especially in poor responders, that LH is needed even in the follicular phase because LH will synergize with FSH to support estrogen production, and we also know it is of paramount importance in the luteal phase for supporting corpus luteum functions. So LH is important for your ovarian response, for your fertilization rate, the proportion of good quality embryos, and also increasing the probability of pregnancy. So how do you define the optimum ALH levels? The optimum ALH level should be more than 1.2 but less than 5 IU per liter in the stimulation cycles, especially when you start the cycle. When the LH level is suppressed, you have suppression of the granular cell proliferation, your follicular atrasias, your premature luteinization and oocyte development is compromised. And when you do not reach the ALH threshold, you find that the follicular growth is impaired. You have got no full oocyte maturation. Now, which are these patients which need LH? There are two types of patients. One, which have got profound ALH suppression. Your patients of hypo, which will definitely not only need high doses of FSH, but will need LH also for ensure follicular growth. Or patients in whom you have made them profound LH suppression by giving them the GnRH agonist depot injection. And the second group is patients in whom normal ALH levels are less effective. Now, the patients with profound ALH suppression is very easy. You see their ALH levels and they are 0.1, 0.2, definitely less than 1. But the group in which the normal LH levels are less effective, and this is the group of the elderly patients or patients who are over 35. And we know that when LH level is low, you need more consumption of FSH, you need more number of days of stimulation, you get less number of mature oocytes, decreased fertilization rates, implantation rates, and it's also related to increased early pregnancy losses. So as women grow older, both FSH and LH rise. This is because of progressive ovarian resistance with increasing age. And the LH stimulation of ovarian and androgen production begins to decline as early as in early 30s. So with increasing age, the ovary becomes less LH sensitive, producing less androgen. And that is the reason why your poor responders will do better if you give a combination of FSH and LH rather than giving them only FSH, because they need that LH to have follicles recruit and not only get recruited but also grow. How do you pick up these patients? By their age, their ovarian preserve. But sometimes if you have missed it, you'll find that when you scan them on day 5, there is normal follicular recruitment. There are good follicles which have got recruited more than 8 millimeters in diameter, and your E2 levels are more than 100 if you measure them. But when you see them subsequently after 3 to 4 days, you'll find that there is a plateau of follicular growth, There is no exponential increase in the E2 levels nor the follicular size, even when you have continued with the same FSH dose. And these are the patients who would perhaps have done better with LH addition. You also find patients who have got premature progesterone increase. These are the patients who would have done better if you had added LH in the early part of the stimulation cycle. So who will benefit? Your hypo patients, patients who are more than 35 years of age, profound ALH suppression, low LH following GnRH antagon treatments, or patients in whom the progesterone level is more than 1.5 on the day of HCG trigger. Your moderate and severe PORs, hypo response to your stimulation despite normal ovarian reserve test, poor follicular genesis. As I said, very classic. You get good recruitment, but then you find that the follicles are not growing. These are the patients who would have done better if they had an LH added before. So LH pre-treatment in poor responders, you find that definitely the pregnancy rates have gone much higher from 7% to 37%. So pre-treatment with either recombinant LH or pre-treatment with HMGs preceding the administration will also help these patients. Use of long-acting FSH, which has been now getting freely available in our country as polytropin alpha. You give it and then you wait for 8 days to see how the response is, and then maybe a certain sect of your patients will need an additional 2-3 days. Double stimulation, as I said, in fertility preservation, it can be also used in poor responders but doesn't work as effective as in patients in whom you want to do fertility preservation. You do one round of oocyte retrieval, wait for 3 days, and you start the stimulation, because we know now that follicle recruitment happens in waves, and there are papers to suggest that the second stimulation has given better numbers and better quality of oocytes. The oocytes which are stimulated in the luteal phase have given a better response. Protocols for fertility preservation, depending on when they come, how much time you have, you can put them on the conventional protocol, which is often the best. But you can also put a random start protocol, use of letrozole, especially in hormone-sensitive cancers, and as I said, in double stimulation patients. When do you need to give dual or double trigger? When you have a previous record of having immature oocytes, when you have got poor responders, also seen with lower FSH and ALH levels on day 2 and low LH on the day of trigger, and patients who have been on prolonged OCP cycles, they do not respond extremely well to GnRH agonist. So GnRH agonist trigger should be used only when the ALH level is more than 0.5 on the day of trigger. Otherwise, you sometimes land up with an empty follicle-like syndrome. Dual trigger is when the GnRH agonist and the HCG is administered concomitantly 35 to 37 hours prior to oocyte retrieval. And double trigger is when the GnRH agonist is given 40 hours before and the HCG is given around 34 hours before the oocyte retrieval. What is the hypothesis? It mimics the natural cycle surge, and especially, as I said, if you have downregulated the patient with OC pills in the previous cycle, they generally do not show the ALH surge despite putting them on the agonist treatment, and such patients you may have to give a double or a dual trigger. So a dual trigger is given in cases with diminished ovarian response. You want to ensure you get all M2 of all the follicles that are there, previous history of poor fertilizations or poor oocyte maturity, And double trigger, as I said, when you have had high incidence of immature follicles in the previous cycle and low, less than 50% fault. So my take home message is pre-treatment in an antagon cycles may be beneficial for scheduling and your cycles or even synchronization of the follicular development, especially when you have cyst formers. Use of progestogens for inhibition of LH surge is effective and safe, but to be used only in the non-transfer context. Cost of progestogens compared with GnRH analogs may also be seen to be a beneficial effect. COS initiated in late follicular phase prevents premature LH surge and is an effective protocol in combination with embryo cryopreservation in a normo-ovulatory cycle. Single dose of long-acting antagon in the previous luteal phase is effective in down regulating and may perhaps become the new protocol, allowing cycle programming and also reduce the incidence of hyperstimulation. Individualized protocols based on ovarian reserve test increase safety and effectiveness, although the live birth rate may not be different. Natural, modified natural, and mild stimulation, especially mild stimulation, decreases the burden of treatment. Double stimulation in poor responders should be used only in the context of clinical research, but is a good option, as I said, for fertility preservation. Random start protocols have a significant advantage by reducing the total time without compromising on the oocyte yield, especially for fertility preservation. Adding letrozole to gonadotrophins is effective, safe, and will minimize the risk of high E2 exposure. Dual or double trigger improves outcomes in patients with poor fertilization, abnormal follicular maturation, and poor oocyte. Hyperstimulation can be prevented by risk assessment with optimization of treatment and something that we call as segmentation protocols, where you do all freeze and then transfer in a natural cycle. Further studies, as we all know, are needed, especially to know what will be the reproductive obstetrics, and more important now I feel is a long-term neonatal outcomes, especially when we do frozen embryo transfers, because we really do not know what would be the genetic outcomes in such cases when the embryos are freezed for a prolonged period. So thank you very much for a patient hearing.
Thank you, Doctor. May I request Dr. K. May I please request Dr. Satyam Pillai to kindly present the memento to Dr. Ameet Patki on this oration. Thank you, sir, for this enriching oration. Your insights have truly broadened our perspective. We now shift focus to a clinically relevant crossroads in women's health. When should oncology opinion be sought in gynecology?